Hi, and thank you for joining us today. My name is Erin Williams, and I work with the Association of Schools and Programs of Public Health. The ASPPH is a sponsoring organization with the National Board of Public Health Examiners for the Certified in Public Health credential. And we are pleased to have you here today as part of our summer webinar series for the CPH exam review. Today, we're going to be talking about public health history, systems, and leadership. But first, before we get into things, I'd like to talk a little bit about the resources we have available. If you've joined us for some of our other study webinars, you've already heard this, so I'll be brief, but there are 6 different items that we have available to you, and we recommend that you visit. And you can access all of these resources on the nbphe.org website, and it's going to be /CPH-study-resources. First of that, we have the content outline. The content outline is going to go over the 10 content areas which are covered equitably on the exam, and it's going to have within each of those content areas, it will have the job tasks that are relevant within each area to give you a real good idea of the different types of subject matter and content that you need to be aware of. Next, we have just some general sample questions in the format of the CPH exam if you haven't seen those before, and those are free. They're a static set of questions on the NBPHE page, but you can take a look at those and get an idea of the type of questions. Next, we have a sample mini exam of 50 questions. That is going to be a static data set of questions, but you can go through it as a practice exam, and that's all free as well. And then we have several upcoming webinars, lectures, and question and answer periods, public health law, health policy process, and public health biology and human disease risk. We also will be offering in the fall a special webinar on biostatistics for those that need a little bit more help on that. And then ASPPH has a CPH study guide that we have available. It is $49.99. It is a year-long access, and it is basically a combination of all types of the content areas. It's practice exams. You can either take a 50 question practice exam or a 100 practice question exam, and that's going to let you go through like a real exam. It'll give you detailed analysis of your skill set, of what you got right, what you got wrong. It'll have a detailed explanation of each of the questions as well as resources to do further study on. And each of those exams are going to be unique. It's pulling from a database of over 400 questions, so you are going to get a unique and robust test experience each time you take it. And then lastly, we do recommend a book that was written by our faculty experts at the University of South Florida. They were early adopters of the CPH and highly encourage all their faculty and students to achieve their CPH. And so Karen Lillard, Jamie Corbin, and Hari Venkatachalam from the University of South Florida College of Public Health created this exam review guide. It is what we have partnered with APHA to do a Leadership Institute every year at APHA's annual conference. It is a great resource, and we highly encourage you, if you need some kind of textbook review, that you go out and get this book. It's available via APHA's press on their website. $41.95 for members and $51.95 for non-members. And so I am pleased to go ahead and give you a few moments of housekeeping before we get started. The orange box that you see with the white arrow, if you click on that, that will open up the control view. And in here, you'll be able to see a question dialog box. And at any point in the webinar, go ahead and type in a question you have about the content being discussed. I'm going to be monitoring that question dialog box. And at the end of the presentation, we will have a little time for Q&A. If there's any general questions you have, you can insert those as well, and I'll be answering that as we go along. So, and then this and all of our webinars are archived on the NBPHE website that I referred to earlier. The PowerPoint presentation we posted as a PDF. There is an advanced copy up there right now if you would care to follow along with that. And we are recording the webinar, and we'll be posting that in a few days. So thank you so much for your time. Thank you for joining us today. Let's go ahead and get started. I'm pleased to introduce Donna Peterson. She is Dean of the University of South Florida College of Public Health, and today she'll be talking about public health history, systems, and leadership. Dean Peterson?
Thank you, Erin, and hello, everybody. Thanks for joining us. I'm always happy to meet people who are interested in earning the CPH and participating in this process. There's a way of brief background, and I always say this now, the older I get when I talk about history, I can honestly say that I've lived a lot of this history, and in fact, I'm a founding member of the NBPHE and was very involved in both creating the board, creating the test. And I say that because I think it's important for people to understand that the reason a group of people got together to create this was to help to further professionalize the field of public health. If you think about what goes into something being considered a profession, having some kind of exam is part of that. So we appreciate you joining this movement, and we hope after the series you are fully confident and comfortable and prepared to take the CPH exam and join the group of us who are trying to help professionalize public health. So Erin, if I can have the next slide, please. So what I want to do today briefly, we only have an hour. I won't talk that long because I want to leave time if you have questions at the end. Part of this is just in the spirit of what does it mean to be a professional. We have a common language, we have a common understanding, and so I want to go through a little bit of the historic foundations for our field, and again, the field within which professionals conduct their work, talk about some important information areas in history, systems, and leadership. That's the title of today. Talk specifically about the leadership domain in the exam, and hopefully help you, as I said a moment ago, feel much more confident in your ability to successfully sit for and pass the CPH exam. If I can have the next slide, please. I always start any talk I give about public health to whoever, any audience. I like to ground us in what health is and what public health is. And in the context of this exam and a discussion of history of public health, it's also important to understand where these things came from. So the World Health Organization that was formed after World War II, it defined health. It's the World Health Organization, so they wanted to define health, and they defined it as a complete state of physical, mental, and social well-being. And that's important to understand, that it's not enough to not be diseased or infirm. It is important that we actually be well. And that definition of health then drives how the Institute of Medicine defined public health in 1988 in its very important report, The Future of Public Health. And they said in that report that public health is what we do collectively as societies to create conditions in which people can be healthy, healthy being the way the World Health Organization defines health. Next slide, please. That report, here's a picture of the cover, The Future of Public Health, if you don't have it on your shelves. It was a very important report at the time. It helped define public health. It helped articulate the three core functions of public health, which hopefully you all are familiar with. This diagram on the right, and we'll see it again in this talk. You see the three core functions on the outside of the circle: assessment, policy development, and assurance. Those were the three core functions articulated in the 1988 Institute of Medicine report on the future of public health. Those three core functions have stood the test of time. I think most of us would agree that this is what public health agencies are responsible to achieve. We need to assess data, understand what's happening in our communities, what's the health status, what are some of the opportunities to improve health, what are some of the threats to health. That data then informs the development of policies, programs, interventions, coalitions, all of the things that we do in public health to then make sure that we can assure the health of the population by whatever means they need. Within the circle are what are the 10 essential services of public health. These were developed in the early 90s. A group of folks got together in response to the Future of Public Health report and said, yes, we agree with these three core functions, but we'd like to provide a little more detail so that people understand what those things mean. I find it difficult to remember 10 things. I can remember 3, and I would encourage you to remember 3. And I'll just note here that research is in the middle, which is one of the core functions. And sometimes people say, well, you know, in public health practice, we're busy doing the work. We're not really conducting research. But as a matter of fact, I would argue that all of these functions are shared across all of the sectors that contribute to public health, and that if you are in public health practice, anytime you are launching a new program, trying a new intervention, you are in fact testing a hypothesis, and that gets to the nice purple function, which it is our responsibility to be accountable, to monitor, and to evaluate everything we do, and that evaluation information then feeds right back into the assessment function. Next slide, please. So when we talk about systems in public health, and it's a term that you often hear, people will talk about taking systems approaches, being able to think in systems. This is a field we're still learning about and exploring and trying to define in more concrete terms. But suffice it to say, I think we all appreciate and understand that even though traditional public health agencies, state health departments, local health departments, all the agencies in Washington, the feds that we work with, have the responsibility for public health, have the authority for public health. In fact, many different sectors and agencies and organizations and communities, even themselves, are contributing to public health, regardless of when and how they actually understand or appreciate that. And part of our job is to help make those connections, to make sure there are good communication pathways between all the different sectors in the system. And depending on the issue that we're trying to address, we will engage one or more of these. But certainly in our assessment activities and our policy and advocacy activities, in the leadership activities that I'll describe at the end, it's very important that we understand that we work in a systems context and that we have to be connecting and working with and building coalitions across all of the different components of the community that together collectively create those opportunities for health. Next slide, please. So let me jump back to history. Some people will say that they believe that as long as humans have walked the earth, they've been concerned about their health, whether they understood that or not. We know people, early hominids, did understand that they wanted to keep their waste away from their water and their food sources. And when we think of public health, that's really the foundational basis of public health, is how we manage humans interacting with the environment. We also know from various religious texts and art that we can see and we can glean that there were religious-based practices that were in fact in service to public health. So religious-based cleansing practices and food prohibitions or food things that people were encouraged to eat, and again, not understanding necessarily that they were working in public health. That's what they were doing. We know that long before vaccines were developed in China, there was a practice of presenting people with disease to try to help prevent them from acquiring the disease. So this goes way, way, way back. And through time, there were different theories of diseases in the different eras of human history. In ancient Rome, they were very interested in water. The aqueducts, you may have seen, they used their mathematical, their engineering, their architectural knowledge to bring clean water into Rome. The ancient Greeks were all about being physically fit. It's where the Olympics come from, and they really believed that it was important for your body to be healthy, and that helped people thrive. We then had, over time, we had the humors idea that there were different things in your body that either worked in concert to keep you healthy or that worked against each other to make you ill. And then we had the idea that ill health was a function of moral. If you weren't behaving in a moral manner, if you sinned, that would create illness. And then we had theories relating to bad air, the miasma theories of disease. So it's clearly something that people have been interested in, again, since as long as we understand how people lived. And it makes sense that as human beings, we would want to do whatever we could to maintain our health. Next slide. I'm going to call out just a couple of events that are important in public health history, certainly not all of them, not even close, but a few that really helped shape I think the way as human societies we started to respond to health and opportunities to prevent disease. Obviously, the Black Death, the plague that probably originated in China, was brought to Europe by traders. Traders, Traders, not traders, Traitors. But in the 1300s, just wreaked havoc across Europe. Estimates are that more than half of the population of Europe died as a result of the Black Death. Again, we can see in art how people responded to this. It overwhelmed communities. They couldn't take care of all of the dead. They lost the opportunity to work, to manage farms. It challenged the food supply, and it really reshaped society and led to later historical changes in how we function as societies. Next slide, please. In the 1600s, jumping way ahead here, John Grant was the first person. He was in London, and he was the first person to attempt to catalog why people died and why they got sick. And they were called bills of mortality because he would actually post them in the town. He'd put them on a tree or a pole or something so that people could see over a period of time how many people were ill and how many died and of what causes. And we laugh now when we read this list. The table of notorious diseases includes all kind of interesting things, and the table of casualties, which would be the deaths. Again, we smile at these, but in fact, it's true today that diseases appear mysteriously. We don't necessarily understand their origins. It takes us a while to do the research to understand them. People die. We aren't always sure why. Today, we're seeing people develop a lung disease that people haven't seen before, and they're trying to understand its origins. It appears that the one thing that everyone has in common is that they have vaped. So, and in fact, there's been at least one death that I've heard about. So this notion of paying attention to why people get sick, why they die, what are the causes, goes back to 1661, and is something we continue to do today. The next slide, please. We all know about the smallpox vaccine. Edward Jenner, also in Europe, developed this. And kind of like the Chinese practice, but he didn't give James Phipps, this young boy here, he didn't give him smallpox, he gave him cowpox, which is something related to smallpox. But again, he proved the point that if you could inoculate people with a disease, you expose them to a small amount of the disease, that the immune system would then respond and prevent them from getting that disease afterwards. So a very important advancement in science in public health. The next slide, please. Interest in science, in understanding disease. This was a period of a lot of growth and a lot of faith in science, and a lot of people taking pains to try to understand what was creating, again, those causes of disease and death. This was a very important report by Sir Edwin Chadwick, again in Britain, writing on the conditions of the populations in the London area. You can imagine the mid-1800s, factories, people were moving away from farms, moving into London. We had extreme crowding. We had conditions that were not conducive to health. And so this report becomes a very important report, the first of its kind, where it attempted to link what was happening in the environment, in the society, in the community to health. And not long after that, we have John Snow's famous efforts to understand what was contributing to the cholera outbreak. You see here an image of a map. He, working with a member of the clergy, started to map where the cases of cholera were appearing, and in fact linked this particular cholera outbreak to a particular source of drinking water, and connected it very specifically to the Broad Street pump where people would go to get water, and because no one would listen to him, he just went and removed the handle himself. It's a famous story in public health history, but it also marks the beginning of the field of epidemiology. He's known as the father of that field, and we can see the power of the data, the power of geography and trying to map diseases to place and time in understanding that. It's important to note that the agent, the actual contributor to cholera was not yet known. And again, an important lesson in public health that you don't necessarily need to understand what the agent is to stop the transmission of the disease. Next slide, please. In the United States Marine Hospital Service was formed around the same time period. The country was new, and we had a lot of trade coming into the country. And in fact, ships not only brought goods that we wanted, but they brought the diseases from wherever they brought those diseases from, and the idea, or those goods from, and the idea that maybe we needed to quarantine the ships, the men on the ships, the people on the ships for a certain period of time to make sure they were clear of disease before they actually came into the country was very important at this time period. And so the Marine Hospital Service was formed to manage this quarantine process. And because this was all related to trade, the cities that were ports are where the first health departments were formed. And that makes sense because that was a large contributor to the spread of infectious disease, linked to the environment, trying to stop disease spread. And so creating this partnership between port cities and the United States, starting to form an organized response. In 1912, the United States Marine Hospital Service was actually brought under what became the U.S. Public Health Service. And if you ever wondered why the U.S. Public Health Service has an anchor in its seal, now you know why, because its origins were the Marine Hospital Service. Next slide, please. Okay, now I'm jumping way ahead, skipping a whole bunch of history, but want to talk about two very important reports. Again, that sort of changed the way we think about public health. So the focus for many years had been on environmental conditions, water, waste removal. As the science emerged and bacteriology and vaccines and all that, we were very focused on communicable disease, infectious disease, quarantines, so on and so forth. In 1974, Marc Lalonde, who was the Minister of Health for Canada, issued a very important report called A New Perspective on the Health of Canadians. It is known from henceforth as the Lalonde Report. And why this is important is it was the first time that a nation said, we are increasingly interested in chronic disease and in the factors that contribute to chronic disease, and we want to shift our focus not necessarily away from disease prevention, but we want to add the perspective of health promotion. And so this was a very important point in the history of public health where we started to appreciate that there were other things that contributed to health and quality of life. The United States answered the Lalonde Report 5 years later with the first report from the Surgeon General on healthy people. This was C. Everett Koop was the Surgeon General at the time, and he issued his report on health promotion and disease prevention 5 years later in direct response to the Lalonde Report, also laying out the notion that there was much more to be done in improving the health of a society than simply focused on infectious and communicable diseases. The next slide, please. And I'm going to come back to that in a moment, but right now I want to jump to a very important point about public health in the United States that is not shared by most other countries that I'm aware of, and that is that in public health, in the United States, the responsibility for public health legally rests with the state. And this derives from the 10th Amendment to the U.S. Constitution, what are known as the reserved powers. So if you remember, at the time that the United States was being formed, we were 13 original colonies, you will remember, 13 individual states. They had very, they were all along the coast, but they had been populated by different waves of people coming from Europe. They had different geographic features, different climate features, different agriculture, industry, different viewpoints, and so there was a lot of heated debate when the country was being formed. They didn't want to cede all of their powers to this new country. They wanted to maintain some autonomy as states, and I like to tell my students the easiest way to remember this is we are called the United States of America. We are not just called America. And that was important. So we were coming together as a group of independent states to unite for the purpose of, where it made sense, having an overarching framework, but also retaining some powers for the states. So this is just a very important concept, and I think it helps explain a lot of what happens in the United States and why we do things the way we do. But it's an important concept to understand. Public health responsibility in the United States rests with the level of the state. Next slide, please. And again, just to reinforce this, it comes down to this concept that, again, when they were framing the Constitution, they divided up the powers. They thought about which ones made sense from a central point of view. So you would only want one army. You wouldn't want states having their own armies. You wanted one currency. You didn't want states having their own currencies. You wanted the nation to make treaties with other nations. You didn't want states to do that. You wanted one postal service, and you can see things down here that make sense. And then they were very clear about what states could do. So public education, the local structure, professionals, determining who could be a professional. And then there's a group in the middle where they share things of much interest and much concern to all of us, is collecting taxes. So we are taxed by both, and both can make and enforce laws. But public health is clearly on the reserve powers side of the equation, and it explains some of the ongoing tension that exists in the United States from what happens at the national level versus what happens at the state level. And you'll often hear people raise this issue of states' rights when arguing about decisions that are made by the U.S. Congress. And I think what we saw with the Affordable Care Act, there were assumptions made on how states would behave when the Affordable Care Act was passed that did not, in fact, turn out to be true. I think most apparently, the framers of the Affordable Care Act just assumed that every state would expand the Medicaid program, and that, in fact, did not happen. So that's a great example of this tension. Okay, the next slide, please. Having said that, states have the responsibility, but that doesn't mean that the feds have no interest and no role. They have a huge role, and in fact, they provide almost half of the funds that go to states and communities to support public health and related interventions. They are there to respond to any situation that crosses state lines. So disasters, infectious disease outbreaks, foodborne outbreaks, things that cross state lines is where they come in. And they set broad guidelines and broad policies. I can have the next slide, please. So now, hearkening back to Healthy People, the report in just before the first set of Healthy People objectives. So you're all familiar with the Healthy People objectives. So the Surgeon General's report on Healthy People that followed the Lalonde report set the stage then for the first set of national health objectives for the country. And so those were issued in 1981, I believe, the first set for 1990. So they were 10-year goals. And you can see in 1990, and it's actually fun to go back and read some of these early reports, there were 15 topical areas, there were 226 objectives. And the overall goal was to decrease mortality and increase independence among older adults. And at the time, this was a very important movement in this regard. It provided guidelines. A lot of states then could use that to peg their own plans, and it just became a very important effort. And you can see over time, I won't go through all of this detail, but in the 90s then, as we were assessing or in the 80s, as we were assessing our achievements of the goals for 1990 and preparing for 2020, we added new topical areas, we added more objectives. As we looked ahead to 2020, we added more topic areas, we added more objectives. The 2020 objectives, I meant to say 2010 before, the 2020 objectives, which were now coming to a close, and we're working on the 2030 objectives, almost triple the number of topic areas from 1990 and 6 times the number of objectives, 1,200 objectives, and a much more comprehensive overarching goal, attaining high quality, longer lives free of preventable disease, achieving health equity, creating social and physical environments that promote health and promoting quality of life, healthy development, and healthy behaviors across all life stages. So you can see how our thinking has evolved. You can see how our capacity to set objectives and have information on baselines and targets has advanced dramatically since this time. So I say this, to remind us of the role, but also that these reports matter. When something like the Lalonde report comes out and really challenges us to think in different ways, and then we respond and then we act on it, we can change the way we think about public health. Next slide, please. So again, going back in history, we talked a little bit about how port cities were where the first health departments were established, and that had to do with managing ships coming into the ports. But it wasn't long thereafter that states started creating state health departments. There was a report in Massachusetts that followed the Chadwick report in London, did the same thing for Massachusetts, looked at the environmental factors and things that were contributing to health outcomes in Massachusetts. And one of the recommendations of that report was that they establish a state board of health. And as a result, the state of Massachusetts is the first state to have created a state board of health in the country, and the others soon joined in. And again, going back to the foundational purposes of public health, maintaining waste removal, water, all of those things, pretty much every state health department had that as part of their charge. Nuisance control, which was largely around rats, who were spreaders of disease, of course. Birth and death recording early on, important roles of state health departments. Quarantine, of course, and communicable diseases. And maternal and child health. The Children's Bureau was established in the United States in 1912, and they quickly figured out that they needed to have a presence in every state in order to carry out the work that they thought was important to promote the health of women and children. And so they created actually the first grants and aid funding approach. They got the U.S. Congress to pass legislation to give money to states to support maternal and child health efforts, and they mandated that the funds had to go to a health department. And in 1912, not every state yet had a state health department, but the availability of these funds persuaded them to go ahead and create state health departments. And it's a good example of how Congress and the agencies of the government can use the power of the purse, if you will, to persuade states to do what they want to do when they don't have the authority to just enact policy to compel states to do that because of the 10th Amendment in the Constitution. The next slide, please. In 1968, I found this and I thought it was interesting. The American Public Health Association wrote a report describing what they thought state health departments should do. And I should say here, even though it's obvious, a common quote that I've heard people say: if you've seen one state health department, you've seen one state health department. And that's, again, an important concept. It goes back to the fact that the responsibility for public health rests with states, and so they determine how they're going to address that authority that they have. The populations vary state by state, the topography, the resources, the history. And so each state is going to organize its public health efforts in its own ways. Again, where the federal government comes in with money, that may persuade states to do things. Not always. Some states have rejected funding if they don't want to engage in a certain activity. But APHA came out in 1968 and said, well, state health departments should at least do these four things. They should do surveillance, they should plan, and they should develop programs. Now remember, this is 1968. This is 20 years before the Institute of Medicine articulated core functions. But that's assessment, right, and policy development. They should promote health coverage. So again, health departments, some engage heavily in clinical care services, personal care services for their populations. Others work with the local system to try to make sure there's health coverage. So that's there. Enforcement of standards, creating and enforcing standards, and then providing health services. So again, some agencies did that, not all, and that's true today. Some states are active in that arena and others are not. Next slide, please. So beyond the functions I mentioned before in sanitation, vital records, infectious disease control, nuisance control, and maternal and child health, which every state health department has, you may or may not see these things in a health department. You may see the vaccine program in a health department, tobacco prevention and control, food safety, emergency response, health promotion, HIV, AIDS, and STIs. These are commonly in health departments, not always, but commonly. The next slide, please. And here's where you really start to see the variation. So some health departments are responsible for licensing professionals, reviewing health facilities, whether that's hospitals or long-term care facilities, but not all. Some states have a particular department that does just that. Environmental health is one of those things that is ironic because it was foundational to public health, certainly back in history. But some states over the years said, well, environmental health, environmental protection, that's kind of the same thing, and they might have pulled that out or weakened the health department's efforts in that area. And relatedly, who regulates drinking water, who monitors air pollution, may or may not be in the health department, who does all of the mental health work, the substance abuse work, again, may or may not be in the health department, the medical examiner may or may not be in the health department, the Medicaid program in a few states sits in the health department and others not. The same with services for disabled people, family planning, school health. There are others you can think of, I'm sure. So they may or may not be in the health department. And this is important because wherever you find yourself working, you are going to need to know, if you aren't part of that agency, but you are part of the system, back to that system's responsibility, you need to know where responsibility for these different programs rests. Next slide, please. So here we are back to that diagram that I showed you when we first started. So we have our 3 core functions: assessment, policy, development, assurance. We have our 10 essential services. And over many years, different organizations, different agencies coming together to try to make sure that health departments at the state level for sure, at the local level often, that they actually had the capacity to perform these essential services. They weren't called essential services, they are essential services, that's why they were called that. And so in an effort to really help give traditional public health agencies at the state and local level some more support to say we need to have the capacity to engage in these 10 essential services, the Public Health Accreditation Board, when they were formed and looked for sort of anchor to create their criteria, they looked to the 10 essential services as the anchor for the criteria they created. And so now we see accreditation of public health agencies, which is a huge advancement, and it's based on the 10 essential services. And so that's very helpful. And even though if you've seen one health department, you've seen one health department, this effort is intended to assure that there is at least a foundational level of effort and capacity across all agencies in the United States. May I have the next slide, please? This came out, what year is this? This is about 10 years ago in the New England Journal, and there have been other versions of this, but there was a growing consensus of research and evidence to suggest that, in fact, if we really want to improve health and prevent premature death and promote quality of life, that focusing solely on health care solutions was not going to get us to those goals. So the estimate is about 10% of what contributes to your overall health is due to health care, the availability, the accessibility, affordability, and quality. Do we care about that in public health? Absolutely, but it alone will not achieve the health goals that we seek. Your biology or genetic makeup perhaps contributes a third to your overall health and well-being. Social and environmental factors, as we know, we've been discussing this, probably another fifth at least. But the majority, again, what the research suggests is that it's individual behavior, sometimes called lifestyle, that actually contributes more to your health and well-being. Now, that's not to say that we are putting responsibility on individuals for their own behaviors, because what we also understand is that the social and environmental factors often dictate the extent to which any individual can behave in a manner that is conducive to their health. May I have the next slide, please? Which gets us to all of the work and discussion we've done about the social determinants of health to help people understand a systems approach to public health, which we started with, which people don't always understand. That's not necessarily a concept that just comes easily, but to say, hey, all of these things, whether it's economic stability, your level of employment, your income, your debt, your expenses. We know that healthcare bills are, if not the leading cause of people declaring bankruptcy, it's certainly right up there. That has a huge effect on your economic stability, the community that you live in, what features are in that community that are amenable to health, what kind of education is available, access to food, access to social support, to integration, to being part of community life, and then the healthcare system, which of course is part of the determinants, but that all of these things together work to either promote health or create opportunities for health and quality of life, or they detract from them if they are not there. And so this work has really shaped what we've done over the past 10 or so or more years, really kind of rethinking our approach to public health back to the definition of health. It's not simply about disease prevention. It's about truly promoting well-being of individuals and the societies that they live in. Next slide, please. Which brings us to justice, to health equity, which is now what many of us talk about when we talk about public health. And it is, in some ways, a more inclusive approach to public health. Many of us feel that the name public health hurts us in some ways. It links us to things that people don't like to think about. I've done lots of talks and had conversations in communities where when you say the word public, and they think of public housing and public transportation and things that people hope they don't ever have to use in some measure, or that people are consigned to use, and public health kind of falls into that. So whatever we can do to help people understand what we're about, it certainly creates a more engaged community. These also reflect sort of basic principles of public health, the things that shape how we approach what we do. The idea of change and inclusiveness and transformational, creating just societies that are fair and provide people the opportunities that they need and deserve to enjoy a healthy, high-quality life. Next slide, please. And the United States is not the only group that thinks about this. These are the Sustainable Development Goals that the United Nations published at the end of the millennium. They had issued Millennium Development Goals in the 90s that they hope to have achieved by 2000. And they made great progress. Again, just having goals and putting them out there often creates action where there may not have been any. And so even if you don't achieve them, if you've made progress, that's good. And we did make some progress on some of the Millennium Development Goals, but these are the Sustainable Development Goals. And again, it's around development, but as we see, development being economic development, societal development, but you see in here lots of things that are directly related to health, like number 6, back to clean water. We again, it's foundational. But we also see hunger under number 2, good health and well-being under number 3, and then things that clearly, as we know from our understanding of health and systems and the determinants, the social determinants, things about climate, about energy, about education, about equality, sustainable communities, consumption and production. All of these things contribute to health. We know health and development are inextricably linked, and so this is just one more example of how an organization that's looking at the entire planet can set goals that can then help guide the work of nations and by extension then the work of communities within those nations. The next slide, please. So that's a little bit of history and systems, and I'm just going to spend a few minutes now on the leadership domain of the exam. I'm sure you know already that there was what's called a job task analysis conducted by the National Board in concert with a lot of partners to actually query people who work in public health about what they do in their actual jobs day to day. This exam was originally designed around what schools and programs of public health were teaching, and there's a reason for that. It's a long story. It's an interesting one. But in fact, most exams that are intended to help people show that they have skills necessary for the profession are based on what people actually do in that profession. So it was very important that this work was done. And in the leadership area, there are 22 job tasks that were identified by people working in public health. I'm not going to read them all to you. You can see them. Here are the first 5. So how we use analyses to allocate resources, to prioritize and justify actions. Again, that's right back to the assessment function, policy development and assurance. And then we get into how we do our work as leaders: team building, change management, conflict management, in supporting and improving team performance. Next slide. How we negotiate, how we have performance standards, how we hold ourselves and others accountable, how we make decisions. Again, planning based on external and external assessments. That's that assessment policy development function again. Professional development for ourselves, for others. That's a leadership function. Strategies for collaborative problem solving. Very important in public health. Next slide. Capacity building at all the levels that we work at. We've been talking about that. Communicating a mission, vision, goals to stakeholders. Engaging stakeholders, of course, is an important function, especially in that systems context. Team comes up here a lot in these leadership job tasks. So before we communicate a vision, we need to actually create that vision. We do that in conjunction with stakeholders. Continuous quality improvement. We know that's important in all aspects of our work as leaders. And the next slide, which is the last of the job tasks, organizational performance. So there's individual performance, organizational performance, strategic planning, policies and procedures. Again, here we see that systems notion working across multiple organizations, aligning with legal requirements, efficiency, that's related to quality improvement, and informatics principles. So are we using the latest, greatest knowledge and technology when we engage in the efforts to help us assess in our first core function? So that's the array of leadership tasks that were identified in the job task analysis. I can have the next slide, please. As you can imagine, just looking at that, and this is a multiple choice test, I'm sure you are aware of that. And if you want to have some fun, go home and try to write a multiple choice question on any one of those 22 job tasks. It's a challenge. So know them, understand them in your own roles. I'm sure you engage in a lot of those job tasks. And when you think about what leadership means in public health, it doesn't mean the person at the top of the organization chart. It means the leadership roles that we all engage in our work to promote and protect the health of the public. So you can think about those things. There are 22 of those. There aren't even that many items on the exam from this category. And as I said, these are not easy to write. And so I'm saying this more to give you some comfort that there's not some super secret thing that you need to understand about leadership. I think the questions are very straightforward. As we say with any multiple choice test and any question, read the item carefully. It's a 200-item test, which sounds daunting, but you have plenty of time, and you can take the time to read the item and really think about what the item is asking before you jump to the answers. Read the item, think about what an answer might be, and then look at the answer options. I taught a class last night, and the students had taken a quiz before class, and I actually put a question on there that it's not, I don't like to ask tricky questions, but it was a question that if they didn't read it carefully, they would make the wrong choice. And a lot of them did. And so it was an example to them to say, okay, look, read this question again. Read it carefully. And then I could hear the groans in the room. So it's just a caution or some just advice for you. Read each item, think about an answer, then look at the answer options. And then, as always, you are choosing the best option. If you read the options and say, well, I think a couple of these might be true, you want to choose the one that is the best. That's how this exam has been constructed. Last slide. Yay! I know you can do this. We are very, very excited, as I said at the beginning. The more people that engage with this process and earn the CPH exam, the more it will become just a routine part of what we do, what employers look for. I know one of the criticisms of this exam, certainly early on, is, well, if people don't require it, it doesn't really matter. And my argument back was, well, if no one in your community has the CPH, then why would anyone even know to require it as part of a job recruitment? And in my community here in Tampa, Florida, where we have had students take this exam almost since the very, well, since the very beginning, not almost, since the very beginning. It often appears in job ads here as either required or preferred. And so I urge you to go ahead and jump in and take the exam. And I know you can do this and you can succeed. So with that, I thank you for your time. And we've got some time left for questions. If anybody has any, Erin will let me know.
Yeah, the only question that's been submitted so far, and I'll read that in a second, but if you click on that orange box with the white arrow, that will open up your dialog box. If you would if you have a question that you'd like to submit for Dean Peterson, please do so now. The first question submitted is, if one obtains their MPH with an epidemiology concentration, how will the CPH be beneficial to them? So I think that's kind of a tag on to what you've already discussed, but specifically for that new grad that has their concentration, what is a CPH going to do for them? Why should they do it?
So thank you for asking the question. We're asked it all the time. I'm already getting an MPH, isn't that enough? And again, to fulfill the criteria to be a profession, and again, this isn't like in law or anything, but it's how people typically think about a profession. Having a licensure or a certification exam is one of the criteria that enables someone to claim they are in fact a professional. And so the CPH, the National Board of Public Health Examiners, was a first step in helping professionalize public health. It is a general foundational exam. It does include a lot of content from what you learned in your MPH, and now, as you've seen, linked to job tasks. So it's actually more applicable. I have heard from employers that they're even more confident that requiring the CPH is something they should do, because it says to them, yes, I got a degree, but I also passed the certification test, which assures you that I have basic foundational knowledge and competency to call myself a public health professional. There are efforts underway to develop examinations for the areas within public health. Some of those started and stalled, but there is continuing conversation around that. So one, you should do it because you want to join the ranks of your colleagues who are certified as public health professionals. I don't know where you're living or looking for jobs now, and as I said before, in some communities it hasn't quite caught on yet, because if no one's earning it, then no one would know about it. As I said, in my community, we see it now all the time. I think half of my faculty now have earned the certificate. I think we hit over the 50% mark. My faculty have earned the CPH exam because we feel strongly about it, that it's an important part of our job as an academic institution to help promote the profession of public health. And so that's why. The last why I'll give you comes to you from my husband, who's an engineer, who, unbeknownst to him, as a young man, graduated with an engineering degree from a university that was not yet accredited. The university was accredited, but the engineering program was not yet accredited. He didn't know that, and he wouldn't have known what it meant even if he did. And when engineering went to require a license exam to be able to work as a certain type of engineer, he was very excited, and he went to take the exam and was told that he was not eligible to take the exam because he did not go to an accredited school. His message is, if you have an opportunity to do this, do it now. He wishes he could go back, go to a different university, and take that exam. You may not see any direct effect now, but you don't want to find yourself 20 years from now having to go back and review all of this material when you could have done it now.
Great. Thank you, Donna. Will there be specific questions on the key events that you mentioned?
There may be, which is why I go over all of this. So we try not to get into picayune details like what year did Edwin Chadwick write his report, because this is not a recall exam. It's really an attempt to help you think, but there may well be questions that expect you to know that those things happened, so that you can that we know that you appreciate some of the historical significance of some of these events.
Okay, great. Question is, I wonder if it is beneficial to know all 17 the UN development goals for this, or do you just generally need to know them?
Yeah, you don't need to know all 17.
Okay.
Just know that there is such a thing as
Okay.
UN Sustainable Development Goals. Yeah, no, again, we try very hard. Again, we're not looking for recall, we're looking for, do you understand concepts? Do you have basic knowledge about our field?
Okay. And the same question about the 10 essential functions of public health. Do we need to know these by which area, assessment, policy development and assurance, etc.?
So if, as you heard me say, I can't remember 10 essential services, but I can remember 3 core functions, and I can remember that the 10 essential services link to those 3 core functions, and that it's the basis of accreditation. That's what's important to know. No,
Okay.
we're not gonna ask you what is the eighth essential service. I would defy anyone to answer that question cold.
Gotcha. Here's a question about international relevance. Most of the materials and questions on the online sample exam are related to USA culture and facts. As a foreigner, I'm from Brazil. Where else can I look for material information about USA public health apart from the ones already available on the CPH website that might be present in the exam?
So that's a great question, and we've worked very hard over the years to try to de-US specific the exam. There are some basic concepts that are important to public health and that are important to public health for a domestic audience. This is a US created exam, but we've tried to, whenever possible, take out the references to the United States because it's often not, it often it doesn't add anything. There's no need to do it. Having said that, though, as I said, there are some basic things that are fundamental to the United States system that are important to know. Both of the study guides that Erin mentioned at the beginning are going to be very, very helpful in that regard. So the one that the National Board produced and the APHA study guide both go into a lot of good depth on these issues and will cover pretty much anything you'll need to know for the exam and are just good to know anyway
Great.
about public health.
Can you give some guidelines about how many hours we should study for the exam?
Oh my, well, that's hard to say because it depends on where you are. If you're a current student and you're taking these classes now, the material's probably fresh in your mind. You've already got your notes, probably a couple weeks, a couple hours here and there would probably suffice. On the other hand, if you've been away from it for a while and you're going to want to go back and remember all those epi formulas and different study designs and biostat tests and that may require more time. I will tell you that my faculty that have taken it, by and large, now whether they're just telling me this, I don't know, but they tell me that in most cases they really don't prepare at all. They go online, some of the resources Erin shared, they kind of get a feel for the exam and what the questions are like, and they say, yeah, just sort of by being alive in the world and being part of a public health organization or an academic institution, this is how we live. This is how we do our work. So, I wouldn't go in cold. I mean, I would review. You've got a lot of resources. I would review, and maybe, if you do one good review, take the practice test and feel like you're doing fine, then you're good to go. So I really can't answer that specifically. It's really up to you and kind of how comfortable you are with the material.
No, that's some good guidance. Along of those lines, can you talk about if you take the exam the first time and you don't pass, do you have any suggestions for how to go back and attempt the exam again?
So I believe, and Erin can correct me if I'm wrong, you get a score report by section, right?
Yes.
Yeah.
Yeah.
So you'll know where you did well and where you didn't, and that would provide you very clear guidance on where you need to go back and review materials or access colleagues or former professors. Take advantage of the study session, like we do the Learning Institute at APHA every year. That's coming up in November. You might want to seek those things out and pay attention to those areas where you didn't do as well.
Right. And then can you talk about just the format of the exam in general, Donna? Just kind of explain what they should expect, number of questions, that kind of thing.
So there are 200 multiple choice questions, which is why it's absolutely a good idea to um, look at some of the practice questions and some of the practice exams for content, yes, but also for the format, so you get used to what multiple choice tests look like if you haven't seen one in a while. I will tell you, this exam was created with very sophisticated and high-level guidance, and people who write items for this exam go through a very rigorous training on how to write good multiple choice test questions. Turns out a lot of us really don't know how to do that very well. So you will not ever see a question written like, which of the following is not applicable to this situation? We don't write those kind of questions. You will never see a question that has an option, all of the above. You will never see a question where the options aren't all legitimate possible options. So we don't make up stuff. So it's good to go through it just to get a feel for what multiple choice items are like. There are 200 of them. You get several breaks, as I understand it. There are no calculations required. Again, this is not a math test. So if there's a question, for instance, on positive predictive value, it will give you the answer choices will be, A times B over C, B times, what we want to know is that you understand how to derive the positive predictive value, not that you can do the math. Okay, so there will be no calculations. I believe you're given a sort of whiteboard or scratch paper or something. You can't bring anything in with you, but there is something if you want to write things down to organize your thoughts. People finish the exam. That's not an issue, even though it sounds like, whoa, 200 items is daunting. But you do get breaks. I will tell you, early on, we used to write these long scenarios that you'd have to read. By the time you got to the question, you would have forgotten what you. So we've stopped that. The questions are pretty straightforward. Occasionally, there will be a small vignette, and there may be 2 or 3 questions that follow that vignette, but there's only a few of those anymore. We used to do a lot of that, and we kind of stopped because it was just too hard. It was exhausting. And there's even a place where you can make comments. If you look at an item and say, okay, this is a terrible item. Who wrote this? You should be fired. Please don't say that. Be kind to us. But, if you see something and say, I read this item and here's what I thought the answer was, and that's not any of the options, and you may have missed the boat on this. That's fine. We get those comments, and we do look at them. We review items routinely to make sure that they are robust and that they discriminate, and that they're fair.
Great. Test taking strategies. If I don't know a question, should I leave it blank? Will it hurt me? Should I just go ahead and answer it?
Yeah, no, this isn't like, what's the test where you actually lose points if you pick the wrong answer? This isn't like that. So if you don't answer it or you pick the wrong answer, it's the same. So you might as well go ahead and guess. You have a 25% chance of getting it right. And, again, when you look at an item and you might say, I've never heard of this before, but sometimes even looking at the options, you might say, oh, well, okay, I know what that is, and I don't think that's what this is. So, sometimes you can eliminate some options and get close to the right one.
Great. And then can you talk about scoring? You had mentioned 200 questions. How many questions do you have to get right?
I can't answer that because we score each exam form, is the terminology, based on the population that takes it. So because we have to assure equity across exam administrations, and we are always adding items and retiring items. There are test items on every exam that we're pilot testing, and the examinees change. So some cohorts they score higher, they get more right, some get more wrong. We actually look at items that perform oddly. That's my scientific term. And we make decisions. So there is no hard and fast, you have to get this many right.
Great.
Just do your best.
How many times can I attempt the exam?
845. There's no limit on how many times you can take this exam. I haven't looked at these data lately. There are people that don't pass the first time and take it again, and some do fine and some don't. In my college, because we require passing the exam to graduate, we suggest 2 attempts, and then we assume if someone doesn't pass it after 2 attempts, we assume that they're just not good at standardized tests, which some people just aren't. So we have other alternatives. We've only had to do that twice in 5 years, so most people pass it.
Okay. There are a couple of questions about fees and that kind of thing, and that's all going to be on the NBPHE website. There's a list, and it's the registration fee, the way that you register for the exam. There's an approval process, and depending on what you're affiliated with, if you're a current student or some of our schools have discounted rates, that kind of thing, that's all going to be on the website. You do have to pay for the exam the first time based on your affiliation, and then if you do not pass, there is a discounted rate for that second time. Looking for it, the questions here. Oh, do you have to be recertified for the exam? Once you pass the exam, it's every 2 years you need to meet a certain number of hours, but those are going to be practical hours. That's going to be doing things outside of your regular workday, whether that be volunteering with a community-based organization, going to APHA, participating in item writing, study sessions, webinars, that kind of thing. And you don't have to pay for any of your certification credits. You do have to pay $90, I believe, is the current fee to be recertified every 2 years. Let's see. Some questions about, let's see. Most of this information that people are asking can be found on the NBPHE website, so I'm just going to refer people back to that. And if you have any additional questions that we didn't answer or something occurs to you, please feel free to send me a direct email. I can put you in touch with Dr. Peterson if necessary, or get an answer to your question. My email is ewilliams@asppph.org. Feel free to reach out to me anytime. I'm happy to point you in the right direction. And if I don't know the answer, I'll be happy to get the answer for you. So, Dr. Peterson, do you have any parting words?
Nope, just again, thank you for joining. Thank you for at least considering this. I really do urge you to go ahead and do it. The more of us that have the certification, we're building an army, a team, whatever word you like, to really say to the world, we are a public health profession and we are here to change the world. So thanks for joining us.
Wonderful. Thank you so much. And thank you for joining us today. We do have a couple more webinars coming up, so I hope you will join us again in a couple weeks. Take care. Bye-bye.